Good.
Yes. Without further ado, I'm going to leave the floor to our extraordinary Nicolas.
Thank you so much. Okay, let's get started. I'm going to share my screen. There we go. So welcome everybody. Another little presentation to introduce VM1. It's a very important class in the Barral Institute curriculum. A few words about me first. I'm an osteopath from Switzerland. I live in Switzerland. I did my first VM course about 15 years ago, and it really changed things very deeply, profoundly for me in my understanding of the body, my practice. And I've done numerous courses with the Barral Institute since then. I became certified in visceral manipulation a few years ago, and then started teaching in 2023. So again, we're going to introduce some key concepts and cases related to VM1. The human body is incredibly resilient. I mean, just look at this picture. So there's a tremendous capacity to adapt. But if you repeat stresses on the body and traumas, then eventually you exhaust that adaptation capacity. And this will lead to pain and dysfunction. So the patients we see in our clinics, they've reached that stage where they haven't been able to adapt anymore to the stresses and traumas in their life, and they have pain and dysfunction. So if we take a closer look at it, so you have these insults to the tissues in the form of trauma, surgery, or infection, inflammation from various sources, that whether it's toxins or autoimmunity or stress, etc. But the result of that is that these things will cause tissue changes in the form of scarring or fibrosis. And in relationship to that, you're going to have a loss of tissue elasticity. And again, as a result of that, you're going to have tension and loss of motion. What's really important to understand is that this does not just happen in the musculoskeletal system, but also in the cavities of the body. So for example, it will be affecting the organs and the associated fascias. So what happens when we lose organ mobility? Well, we actually also lose body mobility. Why? Because those fascial tension are going to propagate via chains of fascial tension. Also, the body is very good at protecting itself, and we'll always try to minimize tension and compromise around an area of tension or restriction. So there's going to be a muscular protective reflex or guarding reflex that we can see in our patients when there is an area of fixation or restriction. There are other things like visceral somatic reflexes, so reflex arcs between somatic visceral afferents and somatic efferents involving specific segmental levels in the spine. And to note, these are not just local effects, but they can be quite distant as well. So the other thing that happens is when you lose organ mobility, you also lose organ function. This is the structure-function interrelationship that is a core principle of osteopathy. And so if you're able to work with this structure-function interrelationship, you are able, via the structure, to positively influence function. So you're able to address functional disorders in patients. Here you see a firm adhesion between the bladder and the uterus in the context of a widespread endometriosis. And this person was having surgery for endometriosis. And I think you can easily imagine from this picture that there's going to be significant impact on the urogenital function, but also on the pelvic mechanics, the hip mechanics, the lumbar mobility, etc. Here you see an X-ray with contrast medium in the colon. You can see the hepatic flexure on the right-hand side of the picture and the splenic flexure on the left-hand side. They're both attached to the diaphragm, and look at what happens when the person breathes. So just notice how much things are moving with breathing. Now imagine there is a fixation at the cecum here. So there's a fixation in that location. And imagine how much this would create a chain of tension going all the way up to the diaphragm and possibly to the thorax and shoulder, for example. So Jean-Pierre Barral, he came to understand quite early in his career the importance of the visceral system. And so he's stating, for example, that 90% of the musculoskeletal problems we encounter in clinical practice have a visceral component. So we're not saying a visceral cause, but we're saying a visceral component. So the fixations around the organs and the fascia might be a common reason for the fact that the patients that we treat using only musculoskeletal techniques don't get better for a long time. They would the changes don't sustain with time, so they get better for a few days and then they return to their usual pain and dysfunction. So if we want to look for increased therapeutic effectiveness, we need to start looking at the potentially deeper origin of the musculoskeletal symptoms of our patients. And also, we need to start looking at potential distant origin of the symptoms. So we need to start looking at the body more holistically, more globally, and we need to sometimes or very often move away from the symptomatic area. So looking beyond the musculoskeletal system and beyond the symptomatic area is often the key to resolving chronic dysfunctions in our patients. And I understand most of our patients come to see us for musculoskeletal pains and dysfunctions, but the answer might not be in the musculoskeletal system. A little example here. So you have a person who had appendicitis and ended up having surgery, so an appendectomy. So this will cause a little scar in the right iliac fossa and will cause some increased stress on the right lower extremity. And let's imagine that this person was compensating well for that increased stress for a few months. But then they start running a little bit more, doing more football or whatever it is. So they increase the demand on that right lower extremity. And suddenly, after 6 months, they start having foot pain. So they suddenly are unable to compensate for all these stresses. So here, that's an example of a lesional chain between the appendix scar in the abdomen and the foot. And it might be necessary to treat the foot in that patient, but very likely you won't get lasting results without addressing the restriction in the right iliac fossa. So Jean-Pierre Barral, that's him, he got really interested in organs when one of his patients' back pain was suddenly alleviated by some folk healer in the Alps that did something to that person's stomach. And Jean-Pierre got very curious about it, and he started, this really started a big quest for him to understand the connections between the container, the musculoskeletal system, and the contents, all the soft tissue we have within these body cavities. Jean-Pierre has accumulated more than 50 years of manual therapy experience. He's seen hundreds of thousands of cases and more than 100,000 cases, sorry. And again, he's come up with a few key observations. One is that 90% of musculoskeletal problems have a visceral component. Again, we're talking about component, not cause. So the visceral system plays a significant role in musculoskeletal problem. What he's noticed too is that the body hugs the lesion. So the body is good at protecting itself and will always try to minimize tension and compromise. And particularly when it's around vital structures like nerve, vessel, and organs. So the body will always sort of fold around or encapsulate abnormal tension. And so we as therapists, we should learn to be more passive and receptive and let the tissues speak, or in other words, let the tissues show us where our help is needed. How do we let the tissue speak? Well, we listen. So listening is a fundamental skill that is taught in VM1. And the idea is that when you have abnormal tension somewhere, that tension attracts the adjacent tissues. The body hugs the lesion. And that will happen with the hand as well. When the hand is passive enough, you will feel a little traction. So when we do listening, what we do is we let our hand be pulled by abnormal tension, or we let the tissues pull us into their restriction. So an example here, you have a little restriction at the red cross, and you put your hand very lightly and very neutrally next to that area, and you're going to feel a little pull towards that restriction. Listening is a really powerful tool. It gives you a very rapid response. It takes a few seconds. And what I love about listening is that it gives you a starting point for treatment, even with patients who have two pages worth of pathologies or complaints, or people very complex. It gives you a starting point really quickly. Listening allows you to look at the body in its globality and will highlight key fixations underlying the patient's symptoms. So it has by nature a more causal, it gives by nature a more causal focus to your treatment. You're not going to focus on symptoms too directly. So you're resolving symptoms by looking what's lying underneath instead of just focusing on the symptomatic area. With listening, you can be very focused and precise in your treatments. And listening is truly global in the sense that it incorporates the whole body and all the tissues. You're not doing musculoskeletal listening or visceral listening. You're listening at the body as a whole. And it's really a foundation skill, part of Barral's approach, not just for VM, but also for neural, for vascular, etc. So let's talk about VM1 a little bit. Here's a sagittal section of the abdomen with its thin peritoneal wrapping, so that the red line, red going around the abdomen, that's the peritoneal wrapping. In VM1, we look at, so it's a 4-day class, and we look at abdominal organs, specifically the organs within the peritoneal cavity. So that's the liver here, stomach, small intestine there, the gallbladder that we don't see underneath the liver, and the colon. So retroperitoneal organs like the pancreas or the kidney that we don't see here, they're covered in further classes, VM2 specifically. So what we do in VM1 is we review key aspects of anatomy and physiology of the peritoneal cavity and its contents. We learn about and practice listening. We learn to treat with induction. So induction is a very gentle and powerful technique that is also based on listening. And what I love about induction is that it's truly a 3D technique, and it allows to release complex strain patterns. It's again guided by the tissues. We also, for each organ that we see in VM1, we learn techniques to treat the common restriction of those organs. So if we take the example of the stomach here, we learn to locate it precisely using landmarking and palpation. We learn about its relationship with the liver here, with the pancreas posteriorly, with the spleen here, for example. And then we learn specific techniques to release, for example, its tension in relationship to the diaphragm above, to the liver medially, and to the greater omentum inferiorly. Okay, I'd like to go through a few clinical cases that will highlight a little bit what this work is about and how we think in visceral manipulation. First case that I'm going to describe briefly is a 30-year-old female with a severe scoliosis. So that's not her actual X-ray, and her X-ray was worse than that one in terms of the curve. She had extensive spinal fusion as a teenager, so Harrington rod through most of her spine. And this lady came to me complaining of frequent neck pain and headaches. And I saw her quite early in my VM career, if you want. What was interesting with her is that she got really lasting relief from the treatment of the upper stomach, diaphragm, esophagus. And that taught me a lesson quite early on, or re-emphasized that for me, that where you want to work and where you think you have to work is not always where the body needs you to work. So in her case, the phrenic nerve was a really important element of her symptoms. So the phrenic nerve is going to the diaphragm and is coming from the neck, specifically C3 to C5. And it innervates the upper peritoneal cavity. So when you work on the diaphragm or upper peritoneum or lower chest, this whole area around the diaphragm, you're going to have an effect on the phrenic nerve, and reflexively, you're going to have an effect on the neck. The other thing is that the esophagus is somehow attached to the cranial base via the pharyngobasilar fascia that you see here. And this attachment means that you could have cranial-based dysfunction from tension in the esophagus or stomach. So how do you know in practice where you need to work, what element of that body you need to help release? Well, you will use listening, and listening will help you determine which areas need to be treated first. So in some people, you might have to release the cranial base to have an effect on the esophagus. And in her case, it was mostly the diaphragm area or esophagus to release neck and cranial base. So again, with listening, you'll get a starting point, even with seemingly very complex patients. Another case is a 45-year-old female. She had pain in the right shoulder chronically, and that was particularly evident when she was extending the shoulder back, like in that rock climbing. She was a rock climber, so in a picture, and in similar motion to what you see in the picture here. And she got an immediate improvement in range of motion and pain after manipulating her liver. So in VM1, we have techniques to release tension, for example, between the liver and the diaphragm here. That's where you have the coronary ligaments. And this area, as I said before, it's innervated by the phrenic nerve. And the phrenic nerve happens to be coming from the neck and happens to be having anastomosis with the brachial plexus. So that way, non-traumatic right shoulder dysfunction are often associated with liver problems. So you have irritation of the upper peritoneum, which will irritate phrenic nerve, which will cause dysfunction in the shoulder, in the right shoulder. The next case is a 32-year-old male who came complaining of right lower abdominal pain as well as testicular pain. And he got some pretty rapid relief from treatment of the intestinal loops, mesenteric root, and inguinal canal. So I'll show you more details here. Here is the mesenteric root. So that's the attachment of the small intestine on the back wall of the abdomen. You can see it here in this image. And the mesenteric root is a structure made of peritoneum. That's the back wall of the abdomen with its peritoneal wrapping. And peritoneum is continuous over the pelvic organs. Here you can see the peritoneum overlapping, covering the bladder. Now, behind the mesenteric root here, you have vessels going to the testes or arteries in females. So the gonadal vessels. And tension in the mesenteric root can potentially affect flow circulation through these vessels. So in this case, there's several things at play, but potential peritoneal tension affecting flow in the gonadal vessels on the right. Peritoneum tension being carried all the way to the pelvis, and also affecting that way the inguinal canal, where some nerves go to the scrotum, and so affecting the testes that way, or the right testicle in that particular case. So again, a chain of tension that can potentially go all the way from the small intestine to the attachment of the intestine to the back wall, and then transmitted through the peritoneum to the pelvic area. The next case is a 66-year-old male who was complaining of abdominal pain and chronic diarrhea. He had colitis in the past, but that was treated medically with steroids. But he continued having diarrhea way after that colitis ceased. And in him, we treated the colon, in particular the hepatic flexure of the colon, and he could stop taking Imodium quite rapidly after that treatment. So what's happening? You can see the hepatic flexure of the colon here. And this is one of the key areas of the colon, because you have a sharp angle. And anytime you have a sharp angle, you have a potential for compromised blood flow. So the blood flow is usually reduced and it's easily compromised. So when you release a restriction here, you improve blood flow throughout the colon. The other thing is we have the enteric nervous system. So these nerve plexi through the wall of the colon and small intestine. And when you release tension on an area of the colon, you reduce irritation on the nerves within the wall of the colon, and this will have a reflex effect potentially on the whole colon. So change the motility patterns within the colon. So you could have a single area of fixation and an effect throughout the colon from that fixation. And diarrhea in the case of the patient, that patient. The last case I'm going to mention is a young mom who had this intense stress and a pretty debilitating left upper shoulder pain in the trapezius area. And that was preventing her from sleeping, and she was not very happy about that. And she'd seen quite a few people, massage therapists and physiotherapists, and that pain was not going away. I did what I normally do. I listened, and I found this very important tension on the stomach. So I worked on the stomach, and she got a lasting relief of a left shoulder pain from manipulation of the stomach. So again, another case that clearly demonstrates a connection between the visceral system and the musculoskeletal system. So what happens when you're working on the stomach? The stomach is surrounded by vagal plexi. So you have the left vagal plexus on the front of the stomach and the right vagal plexus on the back of the stomach. And that left-right relationship, front and back, is related to the rotation of the stomach during embryological development. So when you work on the stomach, you always have an effect on vagal tone. And when you improve vagal tone, you are reducing muscle tone. And you have a positive effect on nociceptive inputs. But also there's a mechanical connection between the vagus nerve and the accessory nerve. They both come out from the jugular foramen at the back of the head. So changing the attention on the vagus nerve can have a carry-on effect through the accessory nerve, and thus on the tone of the trapezius muscle. If you have a burning question now or comments around cases you've seen in clinic that are relevant to the few organs that we mentioned, so liver, stomach, gallbladder, small intestine, and colon, we can listen to you now, or otherwise I'll just finish my presentation. Maybe I'll just finish. I've got two more slides, and then we'll
Sounds like a good
open
idea.
up for questions. So to sum up with VM1, what we're going to do is we're going to start looking at the bodies in a more global, integrated way. During that class, you will get a chance to better appreciate the connections between the different systems. We'll use musculoskeletal tests before and after a visceral technique, and you'll see the effect that it has on the musculoskeletal system when you release something deeper in the body. As I mentioned before, we'll learn to move further away from symptoms to address the root cause of pains and dysfunction, which often have a visceral component, like we mentioned several times. And with VM1, you will broaden the scope of your practice, and you will gain tools to address more directly a variety of functional health issues, because you'll be able to work on that structure function interface related to organs of the abdomen. So it will broaden the scope of your practice if you want. So please join us for VM1, and don't miss this opportunity to discover the fascinating world of visceral manipulation. It really changed me as a therapist, and I'm sure it will change you, and it will take your patient outcomes to the next level. So I'm looking forward to meeting you at a VM1 class soon. Thank you. That's
Thank
all
you
I have.
so much.
And please bring your questions, and let's open up the discussion.
Yeah, we are actually thrilled to have Nicolas for end of April in Copenhagen. So don't miss out on this opportunity and join us for Visceral Manipulation 1